Welcome all to the HPB Cafe number 12. I will not take long time. It is the first time that the HPB Cafe will be CBD accredited. The moderator of today's session is Dr. Ahmed Al-Ghosh, who is a medical oncologist in GI program in our center, Sultan Qaboos Comprehensive Cancer Care and Research Center, and who will moderate this session. So the floor is for you, Dr. Ahmed.
Thank you, Dr. Abdullah. Thank you, everyone, for joining us tonight. Welcome to this 12th HPB Cafe. So thank you, everyone, for joining us again. And as Dr. Abdullah previously said, so we will have two talks. First talk will be presented by Dr. Samah Al-Alawi, who is a senior surgical resident. And then we will move to the second talk with Prof. Fabrizio. So our first talk will be about post-op adjuvant hepatic arterial infusion chemotherapy for folks based in hepatocellular carcinoma with microvascular invasion, which is a phase 3 randomized controlled study. And then we will move to the more detailed talk about perioperative immunotherapy and HCC surgical management, detailed by Prof. Fabrizio Roman. So just a few words about the shifting paradigm, if we can say, in HCC. So as we all know, the vast majority of HCC who will be presenting at surgical stage will be and will be resected. Unfortunately, they will recur at no long time after surgical resection, either because of residual microstatic disease or any de novo primary due to their underlying disease. And this led us to a shifting paradigm in the treatment of HCC, mainly in the later stage of her disease, in the second-line settings and in the first-line setting after the TKI was the most commonly used. Now we are being shifted to the use of immunotherapy in second-line and in the first-line metastatic setting, and now what is being studied with the immunotherapy after surgical resection in the adjuvant setting, or TKI in the adjuvant setting also. So why do we care a lot about immunotherapy, as it will be detailed by the Prof. Fabrizio regarding the immunotherapy role in the neoadjuvant setting? Because as we know, in the most of the solid tumor, immunotherapy is gaining a more important role on a daily basis in the management of this type of tumor, mainly because it can eliminate some micrometastatic disease not visualized on imaging, or it can lead to cytoreduction of primary tumor, maybe easing the role and the task of the surgeon to operate patient and to decrease the risk of relapse. So not to delay you, I will leave you with the first talk with Dr. Samah Al-Alawi to present the post-op adjuvant hepatic arterial infusion chemotherapy with FOLFOX and HCC with microvascular invasion. Please, Dr. Samah.
So good evening, everyone. I'm Samah Al-Alawi, R5 general surgery resident. I'll be presenting about post-operative adjuvant hepatic arterial infusion chemotherapy with FOLFOX in hepatocellular carcinoma with microvascular invasion. So hepatocellular carcinomas account for 90% of cases of primary liver cancer, and 70% of cases they present uncurative. Surgical resection is the main curative treatment option, but recurrence is high as 70 to 80%. The incidence of microvascular invasion with hepatocellular carcinoma account for 30 to 50%. Microvascular invasion is the key risk factor for early recurrence in HCC after surgical resection. So despite availability of variant adjuvant therapy, there is no that reduce the recurrence and prolong the overall survival. So as I was mentioning, there is no global consensus on the recommendation of adjuvant therapies after resection of HCC. So transarterial therapies for primary liver tumors, they are image-guided local regional therapy, which plays important role in the treatment for patients with HCC. There are various types like bland embolization, transarterial chemoembolization, drug-eluted beat chemoembolization, selective internal radioembolization therapy, and hepatic artery infusion. What's the rationale behind the intra-arterial therapy is to reduce the systemic toxicity and offering more local control of the tumor. So this is a phase 3 multi-center prospective randomized controlled trial, which was published in 2022 by American Society of Clinical Oncology. It was conducted in China at 5 centers. The inclusion criteria in the study were age from 18 to 75, histologically confirmed HCC with microvascular invasion, no neoadjuvant therapy, performance score less than 2, absence of macrovascular invasion or distal metastasis, absence of intrahepatic or extrahepatic recurrence at radiological follow-up from 4 to 6 weeks after surgery, and adequate hematological, hepatic, and renal function. The exclusion criteria are R1 resection, severe functional impairment, previous or concomitant chemotherapy, history of organ transplantation, neurological or psychiatric illness, esophageal or variceal bleeding with hepatic encephalopathy within 30 days from the randomization. The aim of study is to report the efficacy and the safety of postoperative adjuvant hepatic arterial infusion chemotherapy with FOLFOX, 5-fluorouracil, and oxaliplatin in hepatocellular carcinoma patient with microvascular invasion. The trial design and treatment plan were they get surgical resection as per protocol. All resection margin were negative. Microvascular invasion was defined as a tumor within vascular space lined by endothelium that was visible only in microscopy. After 4 to 6 weeks, all patients were randomly assigned to receive either 2 cycles of adjuvant hepatic artery infusion chemotherapy, which were the treatment group, or routine follow-up without adjuvant treatment. They were like the control group. And patients were randomly assigned 1-to-1 using computer-generated random assignment sequence at the clinical trial center. And the detail of randomization and allocation were provided by sequentially numbered, sealed envelope prepared by the statistician who was involved in the trial. Hepatic artery infusion chemotherapy, the procedure was they punctured the femoral artery and they can catheterize it, and then superior mesenteric artery angiography and hepatic artery angiography were performed to confirm inclusion criteria. And then after hepatic artery was intubated, then patient shifted to the ward with indwelling catheter. And the catheter is connected to a pump which with the chemotherapeutic agent, and the regimen was oxaliplatin, 85 milligram per meter square for 0 to 3 hours in day 1. Leucovorin 400 milligram per meter square from 3 to 4.5 hours in day 1, and 5-fluorouracil 400 milligram per meter square from 4.5 to 6.5 hours once in day 1, and then 2,400 milligram per meter square once over 46 hours from day 1 to day 3. And then once the regimen is over, the catheter is pulled out and patients were discharged after complete hemostasis from the puncture site. And the interval between the 2 cycles was set at 4 to 5 weeks. And during this period, before the 2nd cycle, if the patient had macroscopic recurrence, intrahepatic or extrahepatic, they received TACE, not 2nd cycle of hepatic artery infusion chemotherapy. So the primary endpoint was disease-free survival, and was defined as the interval between the random assignment and first documented recurrence or death. And secondary endpoint was the overall survival, and which was defined at the duration from the date of randomization till death due to all causes. The patient were followed in 2 to 3 months by physical examination, blood test, by alpha-fetoprotein and liver function test, CT or MRI. And if there is any suspicion of recurrence or metastasis were detected, then the patient get hepatic artery angiography and biopsy to confirm it. And both group, if developed recurrence, then they were discussed in MDT, and then they were treated as per the MDT plan. So the sample size estimated on the assumption that median disease-free survival for the control group was 12 months, and the adjuvant group 18 months. And the estimated event to observe this, if 131 patients were enrolled in both group and followed for a period for 24 months. So they conducted the study from June 2016 to August 2021. Initially, they had 351 patients was enrolled in and were eligible for the screening program. And then and then only 315 patients who met the inclusion criteria. 157 patients were in the treatment group and 158 were in the control group. In the treatment group, 4 patients were excluded because they took either herbal medication or they withdrawn their consent, or they didn't follow up or receive targeted therapy. So in the treatment group, they ended up with 143 patients. And in the control group, 15 patients were excluded for reason like they received either targeted therapy, chemotherapy, or they withdrawn their consent, and they ended up with the same number. Demographic and clinical characteristic were comparable between the two groups. There were no difference in the clinical characteristic and in the demographic between the two group of patients. 124 patients, which is a count of 86.7%, they completed the planned 2 cycle of hepatic artery infusion chemotherapy. 18 patients received only 1 cycle. 14 of them, they refused to accept the second cycle due to personal reason. And 4, they received only 1 cycle because they developed intrahepatic recurrence. So they received days. And 1 patient, they didn't receive hepatic artery infusion chemotherapy as planned because they found they have like intrahepatic recurrence, and they received days from the beginning. So the recurrence was diagnosed through hepatic artery angiography. And the recurrence, once the recurrence confirmed, then patient received phase instead of hepatic artery infusion chemotherapy. The median follow-up was 23.7 months for the treatment group and 21.5 months in the control group. And at the last time of follow-up, total of 151 patients had recurrence. 36 of them in the treatment group and 88 were in the control group. And total of 74 deaths, 19 in the treatment group and 28 in the control group. So the median disease-free survival in the treatment group was 20.3 months, but in the control group was 10 months only. And overall survival rate at 1 year was 93.8, in 2 years, 86.4, and 3 years were 80.4 in the treatment group, and in the control group were almost similar. So the results showed that there is no significant difference in the overall survival between the two groups, but there is significant difference in disease-free survival. So the intrahepatic recurrence after HCC, of HCC after hepatectomy is due to intrahepatic dissemination or micrometastasis and microvascular invasion. Local therapy, they had a better survival benefit than the systemic therapy in patients with HCC recurrence. Although the adjuvant test, they showed the same benefit, but due to the embolization effect, it's limited its applicability. And there is no universally accepted adjuvant therapy for patients with HCC and microvascular invasion. So the results from current studies showed that adjuvant hepatic artery infusion chemotherapy with FOLFOX had acceptable survival benefit, acceptable safety profile, and was well tolerated by the patient, and the benefit from disease-free survival in the early 2 years. And the main reason for early recurrence of HCC after surgery is micrometastasis and microvascular invasion. The continuous infusion of FOLFOX has the potential to remove or to eliminate the micrometastasis from the liver parenchyma and reduce the recurrence. And hepatic artery infusion chemotherapy mainly reduces early recurrence, but does not improve the overall survival. And the continuous infusion of the chemotherapeutic agent has adequate local control for the tumor and does not affect the, does not damage the normal healthy remnant liver. So in conclusion, the study had showed that post-operative adjuvant hepatic artery infusion chemotherapy with FOLFOX has significantly improved the disease-free survival benefit with acceptable toxicity in HCC patient with microvascular invasion. Thank you.
Thank you, Doctor, for your presentation. Maybe because of delay of time, if you can move to the next talk by Prof. Fabrizio Romano, and then we will take the question altogether. And please be aware that you can raise your question by sending them by chat, so we will ask all the questions at the end of the session. So now, please welcome Prof. Fabrizio Romano, who is Associate Professor of Surgery in the University of Milan, Bicocca, and the Chief of GI Surgery on Fondazione San Gerardo Monza, Italy. He is involved in multiple research, and he is a reviewer in the Annals of Surgery, Journal of Surgical Oncology, European Journal of Surgical Oncology, and the World Journal of Surgical Oncology, as well as being editorial member of multiple journals, including the GI Cancer Review Letter and World Journal of GI Oncology. Please, Prof. Romano, the floor is yours.
Thank you, all of you. Now I will try to share my screen. Can you see?
Yes.
Okay. Okay. Thank you very much to all of you, and thank you for your kind invitation to this very prestigious HPB Cafe. I want to thank Abdallah and Fabrizio for their invitation, and I hope this is the beginning of a future collaboration. And last but not least, let me thank our resident Federica Ferraina for the help in preparing this presentation. My topic of today is perioperative immunotherapy and HCC surgical management. This is a current subject, and in the next few years, the interest on it will grow enormously because preliminary results are amazing and encouraging. Obviously, I will share the experience from a surgical point of view because I am a surgeon. This is the agenda of my talk. I have no disclosure. So, HCC is ranked among the top 3 causes of cancer death, and the incidence of HCC will grow of up to 55% in the next 20 years. So we will face with the treatment of this disease increasingly in the next future, and strategies to ameliorate treatment results of our patient are strictly needed. HCC is growing not only in incidence, but also in mortality, and we have to do any possible effort to guarantee the improvement in the treatment of this cancer from any point of view: surgical treatment, local regional treatment, and systemic treatment. The increase of the incidence and mortality on the HCCs involving not only USA and Europe, but also the Gulf region. So it's important to share new treatment protocols with these countries, and we have to perform a common effort to offer the better opportunities of cure to our patient. As everybody of you well know, the armamentarium for the treatment of HCC is manifold, and the choice of the treatment for each patient is done according to tumor burden, performance status, and degree of liver dysfunction. We have to consider that surgical treatment is taken into account in about 30% of cases and systemic treatment in about 50% of cases. BCLC nowadays is the algorithm used to attribute the patient to a specific treatment according to the stage of the disease. Otherwise, BCLC is a rigid system which does not foresee a migration strategy from one treatment to another. It does not foresee a combination of therapies for the same patient. And I think that this is the greater limit of this algorithm. Even if in the last 20 years, the BCLC algorithm has evolved and became more and more complex, and many versions has been published, not much has been changed, and the limits of the system are present also in the last version, with allocation to treatment exclusively based on stage. As shown in the 2022 version, the great novelty of this version are related to systemic therapy. In fact, not only sorafenib is considered for advanced stage, but also first-line and second-line schedules of treatment are reported in the last version of BCLC. As told before, surgery is reserved for about 30% of cases of HCC, and is it taken into account and limited to very early stage of HCC in patient fit for it with preserved liver function, child PUG A or B, no portal hypertension, adequate future liver remnant, and a resectable tumor, 1 lesion or no more than 3 lesions with maximum diameters less than 3 centimeters without major vascular invasion. Even according to this very selective and restrictive selection criteria, results in terms of disease-free survival of surgical treatment are dismal. And in fact, even the selection criteria to indicate surgery as first choice treatment for HCC are restricted. Only 15–30% of HCC patients underwent surgical resection. And in front of optimal clinical and surgical outcome of liver surgery, up to 70% of patients experimented a recurrence of the disease in their follow-up. Even in early stage, in which 10% of micrometastasis and 27% of microvascular invasion is present even in lesion for less than 2 centimeters. So surgery should be considered the mainstay and cornerstone of treatment in selected stage of HCC, but the higher recurrence rate up to 70% is without any doubt the Achilles heel of surgical approach. As surgeon, we make a great effort to treat our patient with surgical resection, but results from an oncological point of view are dismal, and rarely we offer a cure to our patient. Factors related to the recurrence of the disease are well known and have been recognized and reported in a lot of papers and in a lot of studies. They include tumor dimension, tumor number, multifocality, and vascular invasion. In the setting of recurrence, we can identify 2 kinds of recurrence. An early one, short time after resection, which can be related to growth or disseminated micrometastasis, and the late recurrence related to the de novo carcinogenesis in remnant cirrhotic liver. The first wave of the curve of recurrence after surgical resection of an HCC significantly and negatively impact overall survival. And for this reason, trying to improve long-term surgical outcome is of primary importance. Development of neoadjuvant and adjuvant treatment should be considered an unmet medical need. A result of systemic neoadjuvant and adjuvant treatment in the last 2 decades has been poor. On the other hand, in the last edition of BCLC systemic therapy has been a little bit standardized in advanced stage of HCC according to line of therapy and type of immunotherapy used for this kind of patient. Molecularly target therapy has been developed since 2008 with sorafenib, and after that, regorafenib and levantinib. And the introduction in clinical practice of these molecules determined a resurgence of interest and enthusiasm in systemic therapy for HCC. As this slide clearly shows, the evolving landscape of systemic therapy of HCC starting in 2007 and 2008, and with evident boost from 2078 with the introduction of many new molecules in the armamentarium of oncologists and hepatologists for the treatment of HCC. The SHARP trial was the first randomized clinical trial on the employment of sorafenib in the setting of the advanced HCC. And the result of this randomized clinical trial were seen as the dawn of a new era, due to the fact that for the first time, there has been an improvement of overall in survival in patients with advanced HCC versus placebo, even if the gain in terms of survival was only of 3 months on overall survival. Until 2017, sorafenib was the only systemic treatment option for advanced HCC, and moreover, no specific systemic treatment section was introduced in BLCC algorithm since 2018. Otherwise, much has changed since 2017. And this diagram clearly shows the improvement in the use of systemic immunotherapy in the setting of HCC. Since 2017, some studies compared the standard of treatment, sorafenib, with other molecules as the REFLECT trial, which compared the lenvatinib versus sorafenib as first-line therapy in advanced HCC patient. The trial showed not inferior overall survival in BCLC-B and C, child A, naive patient between lenvatinib and sorafenib. In the CheckMate 459 trial, a randomized multicentric open-label trial, nivolumab showed a little bit better result against sorafenib, with an overall survival of 22 months, at 24 months of 37% versus 33% in the two groups. 2 more trials are ongoing, and they are the IMbrave 150 and the Himalaya trial. The IMbrave 150 compared atezolizumab plus bevacizumab against sorafenib in advanced HCC in a phase 3 trial. And the results show a median overall survival of 19.2 months against 13.4 months between the two schedules, with an overall survival at 12 months of 60-70% against 54% in the group of atezolizumab plus bevacizumab. In the Himalaya trial, a phase 3 randomized open-label study, the combination of tremelimumab plus durvalumab, the so-called STRIDE combination, showed the best result of survival in advanced HCC stage, with a median overall survival of 16.4 months against 13.8 months in the group treated with sorafenib. And analyzing the 3-year survival rate, it attested that 40% of patients survive, which is the best current result of an immunotherapy schedule in advanced HCC. So the development and the results of immunotherapy in advanced stage HCC patient has driven a change in overall strategy for HCC and provided new ideas for combination and or conversion therapy. In consequence of these results, the first question is if a downstaging could be possible as a direct bridge between systemic therapy and surgery, which is one of the unmet need for the surgeon, but not only the surgeon, but also for oncologists and hepatologists. The answer came in the 2023 with the paper of Alessandro Vitale and et al., a colleague, published on Lancet Oncology, which introduced the concept of conversion therapy based on treatment response and multidisciplinarity, and the inversion of direction from therapeutic hierarchy and conversion or adjuvant therapy, in which the patient has to be treated with the best possible therapy, but the system is not rigid as in the BCLC system. And on the basis of treatment response, the choice of treatment could go not only from up to down, but also from down to up. Patients will respond to systemic therapy could shift from systemic approach to other kind of treatment, including surgery. So, on the contrary of BCLC algorithm, modern treatment of HCC should be considered not only related to stage, but as a network therapy, including for each patient all the treatment modalities actually used, and the better results are obtained with a combination of treatment for the same patient. Otherwise, current guidelines in USA and Europe do not take in consideration an adjuvant or neoadjuvant approach for patients with HCC. American Association for the Study of the Liver and the European Association for the Study of the Liver and the NCCN not included neoadjuvant adjuvant therapy for the patient affected by HCC. The cause of this negative approach could be related to the results of the STORM trial, in which sorafenib has been used in adjuvant setting after resection or ablation of HCC. The use of sorafenib did not impact on recurrence-free survival of patients treated, with a median disease-free survival of 8.5 months versus 8.4 months in the placebo group. Otherwise, the development of perioperative immunotherapy is one of the much debated subjects regarding the treatment of HCC, and preliminary results are promising, as become evident in the next slide. The answer is, might perioperative immunotherapy have a role in advanced early stage HCC combined with surgery? The good result obtained with the use of immunotherapy in patients with advanced HCC and high rate of recurrence following surgery in early and intermediate stage drive to the necessity to overlap of the two treatments with an imbrication and combination of both in the same patient affected by HCC. This approach could be an answer to the surgeon's need regarding a neoadjuvant approach to ameliorate the rate of resection and the result of surgical treatment, to increase the number of patients who undergo liver resection for HCC, and possibly to reduce the incidence of recurrence that, as we saw in the initial part of presentation, is very high, up to 70%. So we can identify three possible scenarios regarding perioperative immunotherapy. The first one is the neoadjuvant treatment in patients with resectable disease. The second one is adjuvant treatment post-resection in patients at high risk or very high risk for recurrence. And the third is neoadjuvant treatment in patients upfront unresectable to turn into resectable. That is the so-called conversion therapy. We analyze each of these scenarios in the next slide. First scenario is the neoadjuvant therapy in patient upfront resectable. This setting include resectable with high risk feature for recurrence, as shown in this slide. analyzing pro and cons of neoadjuvant therapy for the patient with HCC upfront resectable. In the first case, the pro, we can identify the opportunity of reduction of tumor burden, determination of on-treatment response, use of pathological data as surrogate, removal of micrometastases, and prime the immune system to recognize tumor cell after surgery. In front of this, we have obviously some cons, which consist in the risk of dropout from surgical program, delay the time of surgery due to adverse event, and potential clinical deterioration with dropout from the intention to treat surgery. Some studies are completed or are ongoing about neoadjuvant therapy in resectable upfront HCC. As the prime study, which enrolled 42 patients with a complete response after neoadjuvant therapy of 23% and disease-free survival at 6 months of 92% without any delay on surgery, so without any dropout from the intention to treat treatment. Another phase 2 trial with the use of cemiplimab in 20 resectable patients show more than 20% of patients with more than 70% of necrosis after surgery, and 40% of patients with more than 50% of necrosis. This is a surrogate of good response to neoadjuvant immunotherapy, and this probably will reflect in better result in terms of disease-free survival and maybe overall survival. Similar results are shown in another study in which a neoadjuvant schedule with cabozantinib plus nivolumab with an elevated rate of complete or partial pathological response, which can be analyzed from the pathologist after surgical resection, and as before, this could be a surrogate of a good response and maybe reflect in increase in disease-free survival of this patient. This trial provides good result in terms of response to immunotherapy from a RECIST point of view and from pathological point of view, and offer good hope for improvement in overall and disease-free survival per patient amenable of liver resection upfront, but patients which are at risk for recurrence after surgery. So no type like the present for improvement or result of neoadjuvant immunotherapy. Not only neoadjuvant immunotherapy, but also perioperative approach has been used in the treatment of resectable HCC. The first perioperative phase 2 study in HCC used nivolumab versus nivolumab plus ipilimumab. And in this study, the schedule of treatment is reported in this slide with the preoperative treatment after 3 weeks to the start of the treatment surgery, and then a postoperative schedules till up to 2 years. In this study, the results showed, first of all, a safe profile of this approach and a disease-free survival of up to 19 months in patients treated with combination of nivolumab plus ipilimumab against a disease-free survival of 9.4 months with nivolumab alone. The results of neoadjuvant trial are preliminary, but otherwise are promising. They are focused on pathological response after immunotherapy, and data on overall survival and disease-free survival are unfortunately lacking due to the preliminary value of this trial. So we need more large trial and longer follow-up to evaluate the impact of neoadjuvant immunotherapy on overall and disease-free survival of upfront resectable HCC. Some concern otherwise arise from the studies. The time of surgery in accord to immunotherapy and the optimal duration of immunotherapy. The longer is immunotherapy, the better is the response, but the worse are the adverse events. The advantage for clearly resectable HCC, an absence of validated endpoint and surrogate of response, and the more important is that there is not a clear schedule of treatment, which kind of therapy we have to choose for our patient upfront resectable. The second scenario is adjuvant systemic therapy, which is considered one of the breakthrough in the field of hepatocellular carcinoma and is still an unmet need. Above all, because we are able to identify patients with characteristics of high risk for early recurrence of HCC after liver resection. And the adjuvant approach is recognized as the best potential regimen to prevent recurrence and the impact on it. And this obviously will impact on disease-free and not only, but also overall survival of this patient. Moreover, if we recognize a regimen of adjuvant therapy effective on prevention of recurrence, we may be more aggressive with surgical indication and maybe operate more patients in more advanced BCLC stages. Regarding the pro and cons of this approach, pro is the opportunity of treat high-risk population, and we know after surgery which population of patient is at high risk of recurrence. We can reduce the risk of recurrence through the control of micrometastatic disease. We can have a selection of patients according to pathological risk stratification. We have no delay of primary therapy surgery, so we have no dropout from the intention to treatment. Regarding the cons, the removal of tumor antigens reduce the immunological impact of immunotherapy. Resection impact on immune system of the patient, and we have no measurable response of adjuvant treatment. In Brave 050 trial, which is an ongoing trial using atezolizumab plus bevacizumab versus active surveillance for resected or ablated patient at high risk of recurrence, has been published in the Lancet Oncology in the last years. In this trial are included R0 resected or complete response ablated patient with Child-Pugh A at high risk of recurrence of the disease. And the study seems to demonstrate better result in terms of disease-free survival against placebo, with the 12-month disease-free survival of 78% in the treatment group against 65% in the control group. This is the first trial which demonstrate that adjuvant approach with atezolizumab and bevacizumab offer a gain in overall and disease-free survival for the patient treated. Other studies are ongoing, as the EMERALD-2 adjuvant trial will do durvalumab after resection or ablation. Moreover, adjuvant immunotherapy seems to be effective even in the sective or more advanced HCC, which underwent liver resection. We know that in Europe, we usually do not resect BCLC-B or BCLC-C patient, but in China and in Japan and in Korea, usually surgeons resect this kind of patient. And in this stage, according to the following study recently published in 2024 regarding a very high risk of recurrent population, median disease-free survival was 29.7 versus 19.3 months. This is a confirm that adjuvant approach could expand the pool of HCC patients who can benefit from surgery. Keynote 937 trial with the use of pembrolizumab after resection or ablation showing an advantage in disease-free survival in the treatment group, which reach 2 years disease-free survival of 44% versus 21.3% in this kind of patient. These are the study ongoing, and the results are awaited by all the liver community, and in particular by liver surgeon. The community of surgeons await this essential result, because if they will be positive, a rate of patients which currently are not approached with surgery could benefit from this treatment in the next future. The third scenario is the so-called conversion therapy approach, which consists in the systemic treatment with immunotherapy in patients with upfront unresectable HCC, converting it into resectable one with curative intent. Upfront unresectable means a surgical unresectable tumor due to insufficient fetal liver remnant, poor liver function related to the extent of surgery or infiltration of major vascular structure, which involve too aggressive resection. On the other hand, there are unresectable oncologically tumor, in which resection will not offer better result compared to non-surgical treatment, as reported in the recent Science expert consensus. In reported studies, at this pilot 1 on 10 patients, the conversion rate to resectable tumor was 30%. Of notable interest is that neoadjuvant immunotherapy implicated downsizing of the tumor, a downstaging with a reduction of vascular involvement, but also an increase of the future liver remnant before surgery. Another recent study on 10 patients using a combination of PD-1 inhibitors and tyrosine kinase inhibitor resulted in a conversion rate of about 60%. We have to remark that comparing with a group of upfront resectable HCC, the postoperative outcome of patients treated with neoadjuvant immunotherapy, the so-called conversion therapy, the postoperative outcome was similar. So perioperative immunotherapy do not affect surgical outcome and allow to operate the patient with the same safety profile of upfront surgery. Results in terms of disease-free survival and overall are increased in patients with conversion, as shown in this slide. With a conversion rate of 37% and an R0 resection in patients who were not resectable up front of 33%. Another slide which demonstrated that conversion surgery is associated with better survival benefit than palliative care or direct surgery in patients with intermediate or advanced stage HCC. As well, in this open-label single-arm phase 1b study on neoadjuvant cabozantinib plus nivolumab, we have 80% of rate of surgery and 42% of major or complete pathological response after neoadjuvant conversion therapy and surgery, and then improve in disease-free survival. Another study with the use of cemiplimab confirmed good result in terms of pathological response and disease-free survival. Otherwise, some concern of the conversion therapy are still present. The schedule of treatment and the kind of therapy used. Each study uses a different molecule and a different schedule of therapy. We have, in the next future, we have to standardize this kind of approach to have better result, but also to have the opportunity to better analyze the result we will obtain. It's not clear the time span between immunotherapy and surgery, and it has to be clarified in order to do not treat patient too early, so having adverse events related to immunotherapy, and not too late when the effect of immunotherapy is not enough. And the long-term oncological results are lacking. So we are waiting for large randomized trial, multicentric, with the use of specific schedule of immunotherapy to better understand the use of this kind of approach. So what we can say to summarize, combination immunotherapies have demonstrated high response rate and are considered the standard of care in patients with unresectable HCC. And the role of immunotherapy continues to expand. And the decision is necessary to be taken in a multidisciplinary team. Most of patients with HCC are diagnosed at an advanced stage. Downstage conversion therapy may provide patients with an opportunity for curative treatment, resection, or other local regional treatment, and prolonged survival time for patients with advanced HCC. For patients with HCC eligible for curative intent treatment as surgery in the early or very early stage, surgical intervention remains the best opportunity for cure. However, recurrent disease still poses a significant risk. So the positive result of IMbrave 0.0 and other study has shown that immunotherapy can be an efficacious adjuvant therapy in HCC. Last step is the combination of immunotherapy with local regional therapy, such ablation, chemioembolization, radioembolization. And in the next few years, a lot of study start with this subject to answer the question if this combination of therapy will be of help for the treatment of this patient. So a new era is begun, and we're just getting started, but nothing stops this train. Thank you for your kind attention.
Thank you, Prof. Fabrizio, for your elegant presentation and your review of all the available and ongoing studies. So please, the floor is open for questions and discussion, if anyone would like to start with questions. So while waiting for the question, if you may allow me to ask you, please.
Yes.
In front of now, as a medical oncologist, I will ask. I'm not a surgeon, so now with the multiple studies that you presented, and most of them are phase 1, phase 2, and you are lacking phase 3 randomized trial. So if a patient, practically speaking, is operable from your side as a surgeon, so do you think that, surgical point of view, you will wait for the action of immunotherapy and then you will decide on surgery as mainly, as you mentioned in your concern, so maybe we are lacking the correct timing when to operate after neoadjuvant immunotherapy, and whether this immuno will and the surgery following immunotherapy will alter the immune microenvironment of the tumor and lead to micrometastasis dissemination or rapid progression of the disease instead of shrinking the tumor with after immunotherapy has did its job.
From a surgical point of view, I believe that the use of neoadjuvant therapy in a resectable patient could be a great choice to induce a reduction in recurrence rate. The Achilles of surgery are recurrence, up to 70%. We have to fight against these results. And one of the way is neoadjuvant therapy. Surgeon can wait for the efficacy of neoadjuvant immunotherapy and then can operate the patient, I think, with better result compared to surgery alone. In the conversion therapy, surgeon await obviously results of immunotherapy because patient is upfront unresectable, and if immunotherapy give a good result, the patient turn to resectable, and we can offer a good chance for the patient to be treated with a curative intent.
Okay, thank you. Please, I will take a question presented by Prof. Mansour, who is our chairman. So Prof. Mansour is asking, since HCC heterogeneous disease and the current approach adopted to treat as one disease may be misleading because of the different approaches available. So molecular profiling typing is required and direct treatment accordingly in design of such adjuvant treatment. So do you think there will be any progress in this regard, especially, for example, we are opting to do liver biopsy or trying to have molecular profiling before starting any type of treatment? It may lead us and help us in the choosing later line of treatment.
I believe that this is a key point. Having a molecular profile could help us to offer the best treatment, but not only to offer the best treatment, but to avoid treatment not efficient on our patient. So a liver biopsy could help us, and the molecular profile, which obviously has some cost for our systems, but can help us in the choice of the right treatment for the right patient.
So maybe a continuation to this question. I don't know. I know that it is not standard in hepatocellular carcinoma as it is, for example, in lung disease. If we have, for example, with regard to molecular profile, if a patient is a hot tumor, so PD-L1 is very high, maybe 90 or 95%, and we use immunotherapy in the neoadjuvant setting with very good response. As a surgeon, do you consider that we will go for surgery and resection of this primary tumor?
I believe that if you have an optimal response, you can consider the patient for surgery. Some study, according to this subject, is not in accord with my declaration. Some study tell if you have a complete response, do not operate the patient, yes, and wait and see. But I believe that the combination of the two treatment will offer the best choice of disease-free and overall survival for the patient.
Okay. So maybe if you allow me, last question, please. So in the patient, you talked lately about the conversion therapy. I know that this notion is not clear in the HCC, the oligometastatic disease. So if a patient is oligometastatic, for example, if we have single bony lesion with liver lesion, and the patient achieves complete response is the metastatic site. So with the combination immunotherapy with target therapy, atezo or beva, for example. So do you consider this patient is still eligible for surgery from your side?
If you have a complete response of metastatic disease, you can consider the patient as a patient with the disease confined only in the liver. So you can treat the patient with an aggressive approach.
Okay, thank you. So
you're welcome.
I have a question. So thank you for both presenters, Samah and Professor Romano. Just a comment regarding the study that Samah presented regarding the chemotherapy infusion. We don't have the experience in our center of that chemotherapy infusion, neither in HCC nor in colorectal liver mets. And I'm not sure about the the technical, I would say, feasibility of such option. And I knew recently that these catheters are not probably available in every country. So I don't know, Professor Romano, if you have any experience with such technique. And the second question for you, Professor Romano, regarding patient who had like multiple liver HCC, and he's in a good performance status. Do you have like a limit of number where you can consider surgery versus for example, you will go for systemic treatment? For example, I don't know, patient who had like 4, 5, 6 nodules but are resectable. At what limit of number you decide for surgery or you decide for systemic treatment?
I will answer to the last question. BCLC tell us that up to 3 lesions are not amenable of resection. But we know that in Chinese and Japanese study, multinodular HCC can be treated with the surgical approach, and the results are better than the approach suggested by BCLC as chemioembolization or radioembolization or systemic therapy. So the answer to your question is maybe we have to combine these two approaches to guarantee the best result for our patient. If you have 4 lesions in our experience, if we discuss the patient in a multidisciplinary team, we can treat the patient with the resection. But if you want to offer the better choice of disease-free survival, we have to treat the patient with adjuvant schedules. Can you repeat the first question? If we have an experience of intraarterial chemotherapy in HCC?
HCC or even colorectal liver mets?
We do not use this technique in our hospital, but we have a resident who came back from the Mayo Clinic a few months ago, and we suggest to us to start with a protocol of intraarterial chemotherapy before surgery. So we are thinking to start with this kind of protocol to give our patient a new solution.
Thank you.
Thank you, Dr. Abdullah. So just another question by Prof. Mansour Al-Munziri. So in the patient treated with the primary surgical resection or through immunotherapy and they achieved the response and then they recurred, how would you differentiate between a new primary hepatocellular carcinoma and the presence of the background of the patient and recurrence of the primary disease?
It's not so easy to make a differentiation between.
Especially if we don't have a previous biopsy, maybe the biopsy will, the molecular profile, even if it is the same primary, maybe upon progression, it will change.
Maybe then the need of molecular profile is needed in this kind of patient. It's difficult to differentiate a recurrence or a de novo lesion in the setting of cirrhosis of our patient. The debate is open. So if we have a recurrence after surgery and adjuvant immunotherapy, it's difficult to say if you have to start with a new immunotherapy, if you have to treat the patient in another way, or if you have to continue the schedule we used after resection. I really don't have these answers.
Okay, thank you. Yes, the same will be applying, for example, if a patient is immunotherapy and the primary lesion is, for example, shrinking, and we have another lesion that is appearing. So we don't know if it will be a new primary or it is progression of the first primary.
Yes, this is the question, and we have no answer today.
Hopefully we'll get by maybe preview next trials or something will help us. Maybe if any other question by the audience, please. Okay, thank you. So if we have no further question, I would like to thank Samah and Prof. Fabrizio for this nice presentation and your time and your discussion for tonight. And thank you everyone for joining us for this HPB Cafe. Thank you.
Thank you very much, Abdallah. Thank you, Fabrizio, for this invitation. It has been an honor for me to be here.
It's a pleasure for us, Professor Romano. It was a great chance to hear your talk. And thank you to Samah, thank you to Ahmed for being part of this HPB session today.
Thank you. Bye-bye.
Bye, see you soon.